This is my client Brendan, who flew in from Australia to see me, and as you might guess, he's seen multiple practitioners. Has quite a complex medical history. Has had a right meniscectomy in his knee and had surgery on both hips for femoral acetabular impingement. Still has, or has since developed, osteophytes in the left hip. Has functional range in his hip joints in terms of flexion and extension and abduction, but very restricted in terms of rotation in both directions. And his hip flexion is limited to just 90 degrees. If I bring it outward, then I can gain a little bit more, but if I lift it straight up, that's the limit. But I'm now going to focus on his pelvis, and he has a little bit of asymmetry, you might say, anterior ilium on the right or posterior on the left, due to the asymmetry. But going beyond symmetry, beyond the concept of symmetry, asymmetry, is that of testing motion. And I'm trying to take up the slack, and I can't get any movement, and I'm putting more than the usual amount of force. And I'm trying to take up the slack in this structure, and it's so rigid, I'm getting no movement. So let's look at him in prone. So go ahead and roll over. Now, part of his diagnosis is that he has a condition similar to Scheuermann's kyphosis. And the MRI of his sacroiliac does show that those joints are patent. He does have bridging osteophytes in his thoracic spine from T6 to T10. But the good news is most people who have a diagnosis of ankylosing spondylitis, most of them get pathological fusion in the SI joints. But his SI joints are open. And I'll show you that we can induce some motion. So if I try and take up the slack anteriorly, I can do that. So there's a little bit of give. And then I can spring and recoil, and I can see that movement expressed through his lower extremity. So we can actually make him rotate more forward, more anterior rotation through the ilium on both sides. Okay? Now what I was not able to do was to get any inferior mobility. And I can't do that on this side either. Okay? And in terms of superior mobility, we can take up the slack. I see his whole body move, and we get to a stop, to an end point. And then I spring it, and I see the whole body move. So the force is translating rather freely, and I let go, and there's a recoil. And he has the same kind of mobility on this side. When we palpate his sacrotuberous ligaments, it feels like bone. Very, very tight. Okay? In standing, he definitely has a greater anterior pelvic tilt than is the norm, and he's aware of that. Now let's look at the sacrum. He's prominent. So here's my thumb on his left PSIS, and here's my other thumb on the sacrum. And I don't know if that camera angle can capture this or not. This is posterior towards the ceiling. So he looks like he has a forward bent sacrum. And again, we're talking about appearance. So now we have to ask the question, is it mobile? You know, is it treatable? And so I'm going to do a spring on the inferior part of the sacrum. I'm about at S4 and 5. I cannot take up the slack. And I'm putting an excessive amount of force beyond normal, and there's no give whatsoever. So now I'm going to come up on the top of the sacrum, and I can take up a little bit of slack. And now I can spring it, and it recoils. So this makes me optimistic that there is mobility in the SI joints, and that we might be able to affect this pattern. And so I'm going to go ahead and attempt to treat it, and it's going to take me a while, so I'm not going to film the treatment now, but after we finish, I'll go ahead and show you what I did with him. And so I'll stop filming now. So in conclusion, we have, in spite of the diagnosis, we have MRI evidence that his SI joints are not fused. And with the spring testing, we have evidence that it moves into an anterior rotational pattern on each side, but does not have mobility in the opposite direction. So I'll stop filming here.